I'll be speaking on hirsutism. Let's tackle the untackled. So hirsutism is a common clinical condition affecting 5 to 10% of women. It is characterized by the excessive growth of coarse male pattern hair on the androgen-dependent areas of face and body. It frequently causes cosmetic distress and may indicate an underlying hormonal issue. Androgen excess is the cause of hirsutism, and which could be because of the increased production of androgens or could be because of the increased sensitivity of hair follicles to androgens. Causes can be ovarian, adrenal, drug-induced or idiopathic. So the most common cause is PCOS, and which is, we can see in 70 to 80% of the cases. Hypertrichosis and androgen secreting tumors are seen only in 0.5% of the cases. When we go to the adrenal causes, it is the congenital adrenal hyperplasia, which is seen in 2 to 8% of the cases. Non-classic congenital adrenal hyperplasia is seen in only 0.5% of the cases. Adrenal tumors and Cushing syndrome are seen in less than 0.5% of the cases. Drug-induced, although not very common, but we may see cases on the regular basis, which with patients who are taking anabolic steroids, danazol, valproate, phenytoin, minoxidil, glucocorticoids, cyclosporin, progestins, or testosterone, they may come with the complaint of hirsutism. Other causes include hypothyroidism, hyperprolactinemia, hypertrichosis, anorexia nervosa, deuterioma in pregnancy, and menopause. Idiopathic causes are seen in 5 to 15% of the cases. Risk factors include family history, several conditions that cause hirsutism, including congenital adrenal hyperplasia and polycystic ovarian syndrome, which run in families. Women of Mediterranean, Middle Eastern, and South Asian ancestry are more likely to have more body hair with no identifiable cause than are the other women. Obesity, being obese, causes increased androgen production, which can worsen hirsutism. Other types of excess hair, rather than black coarse hair, are vellus hair, which are soft, and they are androgen independent unpigmented hair that covers the entire body of a fetus or newborn. It may also be seen in women with disorders that include anorexia nervosa. Hypertrichosis, the excessive hair growth of androgen, independent hair that is vellus, prominent in non-sexual areas, and most commonly familial or caused by systemic disorders, which I have already mentioned, or because of the oral medications, it can be there. Hypertrichosis is typically managed with hair removal techniques. Unwanted hair, this term refers to any hair growth that the patient finds bothersome. However, the hairs are typically not dark terminal hair, but rather light pigmented hair, which is not a sign of androgen excess. As far as the diagnosis is concerned, it is almost always clinical, based on visual and physical examination. Hirsutism is clinically quantified by a standardized scoring known as modified Ferriman-Galway scoring, which scores 9 of the 11 body areas originally proposed, excluding lower legs and forearm, with a total maximum score of 36. But it is difficult to use clinically this score because most women who seek medical attention for the complaint already are using one or more methods of hair removal. So this is a chart which we all follow, and we see that what all areas are affected. If the FG scores are, abnormal FG score is when the score is more than 8 for black or white females. If it is more than equal to 9 to 10 for Mediterranean and Hispanic Middle Eastern females, more than equal to 2 for Asian females. Use of FG score is to monitor treatment progress, and it is not for the diagnosis or deciding treatment. Idiopathic hirsutism we call when the patient has regular menstrual cycles and normal androgen levels, and it is caused by increased sensitivity to androgens. Often they respond to 5-alpha reductase inhibitors. So for the diagnosis, what we require is, we require to take the history in detail, rate of onset, that is whether it is gradual or it is sudden onset, menstrual history, age at menarche, frequency and regularity of menses. As we know that 8 or fewer menses per year is consistent with oligoovulation, that is, that we all know is because of the PCOS. Signs and symptoms, we need to ask the patient about excessive weight gain, excess hair fall, deepening of voice, decrease in breast size, headache, visual disturbances, pain, or lump in abdomen or galactorrhea. We have to take in detail the intake of drugs and for how many months or years she has been on those drugs like androgens, danazol, 19-norprogesterone, or minoxidil. Family history is also important, as I've already mentioned, and because obesity, infertility, congenital adrenal hyperplasia, and in idiopathic cases, we need to know this history. As far as physical examination is concerned, anthropometry measurements like height, weight, BMI, waist-hip ratio, modified Ferriman-Galway score, all these need to be taken. Hyperinsulinemia is to be ruled out by seeing for acanthosis nigricans. Hyperandrogenism may present in not only as hirsutism, but acne, seborrhea, or alopecia may be there. Virilization, if excessive hair growth is there, it may be associated with alopecia, decreased breast size, deepening voice, clitoral hypertrophy. So we need to look for these signs also. Cushing, if patient has Cushing's disease, we may find stria, moon faces, fragile skin, or proximal myopathy. Galactorrhea may be present in cases of hyperprolactinemia. So for lab evaluation, testosterone levels are to be done. And if the values are raised to more than 200 nanograms per ml, that indicates that in cases of benign pathology like PCOS or congenital adrenal hyperplasia, but definitely the levels are much more if there is malignant tumor of ovary or adrenal. DHEAS, if more than 700 micrograms per ml, then it indicates adrenal cause. 17-hydroxyprogesterone, if the levels are less than 200 nanograms per deciliter, it excludes the congenital adrenal hyperplasia. Levels of more than 200 nanograms per deciliter, we need to do ACTH stimulation test. And if the levels are more than 1000, then it goes in favor of congenital adrenal hyperplasia. LH-FSH ratio, if more than 3, it signifies PCOS. Prolactin levels of more than 25, they tell us about hyperprolactinemia, which we need to investigate further to know the cause. TSH levels, we need to see whether in what range they are so as to diagnose hypothyroidism. 2-hour GTT with 75 gram glucose, we need to see the levels, which will tell us whether it is impaired glucose tolerance or frank diabetes. Pelvic ultrasonography will help us in diagnosing PCOD and ovarian neoplasms. MRI and CT is required for ruling out adrenal pathology. So this is the most common cause we see in our OPDs. Polycystic ovarian syndrome is the most common cause of androgen excess. Symptoms include irregular periods, excess body facial hair, and acne. It affects almost 70 to 80% of the women with hirsutism. So treatment goals, if we want to treat a woman with hirsutism, what is the goal? The goal is to reduce hair growth, whether by cosmetic or medical management, and addressing the underlying issues. So what is the cause? If she has PCOS or congenital adrenal hyperplasia or any of the tumors, we need to address those causes and improve the quality of life. Women, as we all know, whosoever comes with hirsutism has a psychological impact on her health. So we need to deal with these issues also. So once we decide to treat the patient, the treatment includes, the first line treatment is combined oral contraceptives containing cyproterone acetate and ethinyl estradiol. Second line, then we can add on to anti-androgens or direct hair removal methods like electrolysis or laser, and topical agents can also be used for the treatment. So first line, as I've already said, is COCs. Why we want to use COCs? Because they are effective for hirsutism and are less risky than anti-androgens. Because if the woman becomes pregnant while she's on treatment, it is harmful for the male fetus, because male fetus will be less virilized. So we should avoid high androgenic progestins like levonorgestrel because of the metabolic concerns. COCs, the mechanism of action is they cause inhibition of gonadotropin secretion, which causes decrease in ovarian androgen production, and they also cause increase in SHBG, which helps in binding to androgens, reducing free testosterone. So reduction in serum testosterone, both free and total, will result in decrease in the hirsutism. So we have to see the benefits of COCs as They also provide benefit for acne and menstrual cycle regulation. Although treatment with COCs is not FDA approved, but it can be used off-label to treat the hirsutism. Anti-androgens and combination therapy. When to add anti-androgens? If there is suboptimal response after 6 months of COC treatment, the first choice of anti-androgens is spironolactone. So combination therapy with COC plus anti-androgens, that is spironolactone, for severe cases can be used. But we need to wait for at least 6 months for the treatment to be effective. If COCs are not showing any improvement in a patient for 6 months, then only we should add anti-androgens. Monotherapy with anti-androgens is to be avoided, although it is potentially very efficacious for treatment of hirsutism and acne, similar to COCs, but the risk of malformation in the male fetus is very high, so it is to be avoided if we are not sure that the patient is compliant with the contraceptive use or she is not pregnant. So the available anti-androgens are commonly used are spironolactone, that is the first choice. This is an aldosterone and androgen receptor antagonist. Finasteride is another anti-androgen, 5-alpha reductase inhibitor. It is less effective for hirsutism due to type 1 and type 2 enzyme involvement. Flutamide is non-steroidal androgen receptor antagonist associated with hepatotoxicity. So these two are not commonly used. Spironolactone is the one which is commonly used. Spironolactone competes with the dihydrotestosterone for androgen receptors and inhibits androgen biosynthesis. Dosages, we always start with 50 mg twice daily, which can be increased to 100 mg twice daily if required. The side effects include hyperkalemia, which is rare in females with normal renal function, but we need to monitor the levels of serum potassium. Gastrointestinal discomfort is there. Irregular menstrual bleeding may occur in some patients. So serum potassium levels should be monitored regularly. Direct hair removal methods can also be used when the COCs are contraindicated or a patient is not ready to use other drugs. So electrolysis or laser intense pulse light can be used. These will be covered in detail by the next speaker. So considerations are electrolysis is ideal for patients with blonde or white hair. Laser treatments can cause pigmentation issues in darker skin types. Both techniques may require ongoing treatments to maintain results. So treatments which are not routinely recommended are metformin. Metformin has no benefit for hirsutism, so it should not be used. GnRH agonists and antagonists not recommended unless severe hyperandrogenemia and virilization are present. Flutamide, I have already mentioned, because of the hepatotoxicity, is not used. Topical anti-androgen creams can be used, but they are not very effective. Managing coexisting conditions like depression and anxiety, common in females with hirsutism, requiring ongoing management. Impact of treatment. Treating hirsutism may help improve depression and anxiety symptoms. So regularly monitor mood symptoms and adjust treatment accordingly. So in patients with NCCAH, the first-line treatment is COC over glucocorticoids for hirsutism. Glucocorticoid use is indicated when ovulation induction is required. For obese females, the recommendation is lifestyle changes plus pharmacological therapy, but avoid use of COCs for those who are more than 40 years and obese due to increased risk of venous thromboembolism. Weight loss and lifestyle interventions are required. We have to focus on these in addition to the pharmacological therapy. Weight loss improves insulin sensitivity, it reduces androgens and may restore ovulatory cycles. Duration of drug therapy, pharmacological therapy duration, we should continue this therapy during the reproductive years because the underlying cause we will not be able to treat. So whenever patient stops the treatment, she will have recurrence of hirsutism. So if she wants to avoid that, only during when this treatment should be discontinued when she is planning for pregnancy, so that there is no harmful effect on the fetus. So she can continue taking this treatment for a longer time. Anti-androgens are contraindicated in females trying to conceive. So topical therapy with eflornithine, topical inhibitor of hair growth, but often combined with laser therapy for a quicker response. Limitation is high cost and must be used indefinitely for continued efficacy. So to conclude, COCs are the first line therapy for most females. Anti-androgens like spironolactone are added if necessary. Treatments like flutamide, metformin, and GnRH analogs are not routinely recommended. Special populations may require individualized approaches. Thank you.
Should I begin?
Yes.